like to thank all of the presenters for giving us perspectives on these new and emerging therapies. There's a question from the Social Security Administration that actually is quite similar to one that I had also thought of, and that was related to how these newer therapies, whether it's CAR T or gene therapy, would actually lead to significant differences in terms of long-term or late effects compared to the more conventional hematopoietic stem cell transplants. I would also offer, in responding to that, are there any additional late effects that might result in disabilities that one might anticipate from these new therapies? And I'll start with John.
Thanks, Alexis. I think one of the major differences between the newer therapies and the conventional allogeneic transplant setting is that with getting your own cells, you avoid the risk of a new disease, chronic graft versus host disease. So that can be as debilitating as the initial disease, sickle cell disease. So that's one big plus. We're seeing in the autologous gene therapy setting, at least in some of the early work, the potential for late malignancies. That's also the case in the allo setting. Whether those frequencies are going to be higher, lower, or the same, I think time will tell. And furthermore, whether we're going to be able to mitigate those kinds of complications as we go, also time will tell. But that graft versus host disease is at least one example where we're hopeful that a gene therapy approach might even be superior.
David, are there additional considerations for CAR T applications in terms of late effects or disabilities?
Yeah, I think John said it very well, but CAR T cells are not transplant. The major long-term effects that you get with transplant, you can divide between allogeneic and autologous transplant. Allo transplant, you heard a lot about graft versus host disease. It is a new disease. It doesn't happen in everybody, but it's all too frequent, and many patients live their lives for many years, but debilitated. And in fact, if you look at long-term survival, it really is, their lifespan is impacted by graft versus host disease. In the autologous transplant setting, I think late malignancies are a major concern. In some settings after autologous transplant, secondary leukemias and myelodysplastic syndromes can occur in up to 10% of patients. CAR T cells do not involve high doses of chemotherapy. They don't involve transplant. Right now, they are largely autologous, so there's no risk of graft versus host disease. And there is anticipated full recovery. And so the long-term disabilities are expected to be much more limited than with transplant. The major one that I started to touch on was this hypogammaglobulinemia. When we target B-cell malignancies, for right now, we don't have any CAR T cells that spare normal B cells. Normal B cells make antibodies. And so you potentially, when this has been successful, leave patients without the ability to respond to vaccines and to make antibodies, which is particularly relevant in the COVID era, of course. That is a long-term toxicity. We have patients now at 10 years still with limited ability to respond to vaccines. We've learned how to manage that. Oncologists are used to managing that. But for right now, that seems to be the most prominent long-term disability and the propensity for certain kinds of infections because of that.
Great. Steve, did you want to add anything in addition based on the data from the CIBMTR and NMDP?
Well, I think as we have newer methods to prevent graft versus host disease, you heard from Miguel Perales earlier, my big concern is what impact that is going to have on immune reconstitution, and are we going to be leaving people with crippled immune systems, again, unable to respond to vaccinations, or people who trade graft versus host disease from ongoing opportunistic infections. So I think we just need to gather the data and follow these patients longer term.
Great. Another question I have, and it touches a little bit on what Steve mentioned toward the end of his presentation, was about to what extent these emerging therapies can address current disparities that we know that occur both with access as well as with outcomes. So whether it's related to age, race, ethnicity, socioeconomic status. I'm wondering if any of you can speak to how some of these emerging therapies may or may not change the likelihood of challenges for individuals who otherwise have conditions that could be approached with these new approaches.
Well, I can start by saying, the more complicated, the more expensive, the more difficult it will be, and the wider the gap will become. So we have to, to keep that in mind as we roll these out. We're just going to worsen disparities if we don't do something to address access to these kinds of therapies.
I think for CAR T cells that there was some hope that it's a two-edged sword, had the potential to address issues with disparity. Historically, many of these patients have diseases that otherwise might have been amenable to things like bone marrow transplant. And underrepresented minorities are underrepresented, particularly on, say, the National Marrow Donor Program, Be the Match Registry. And so there historically has been difficulty finding a donor for people who don't have a family member match. CAR T cells are autologous, they're self. You don't need a donor, and therefore that had the potential to make them available to anybody, regardless of their background. It turns out, at least early on in this field, we're facing some of the same problems and that John just said with access, with appropriate referrals, getting access to the major medical centers, to these very high-end expensive therapies. There's a lot of effort to that. Whether or not this becomes a moot point, and I hope it does become a moot point, has to do with things Steve was talking about, where now, with the ability to do more and more mismatched transplants, more and more of these underrepresented minorities are going to be able to find unrelated donors. They don't have to be perfectly matched. So I don't know that we've solved that problem yet, certainly.
Yeah, maybe if I could comment, so the technology is there to overcome the HLA barrier to transplantation. It hasn't really provided a lot in terms of overcoming the non-HLA barriers to transplantation. So again, the financial, some of the sociocultural, educational, and how are we going to be able to take care of all the patients who come with different needs than the patients that we've typically been able to care. So the technology is there, and yet creates new problems for us to tackle. And I think we really can't do it without trying to tackle those other problems.
Yeah, I think about it also in the context of the last session, where they were talking about some of the social determinants of health and how it's nearly impossible for us to really grasp the burden of disability unless one were really to take those into consideration. And while I think that we've certainly highlighted many of the technological advances, the idea that there still are some almost unbearable choices that families will need to make, if at all possible, to take advantage of these, I believe is still there. And so it worries me that the disabilities, whether they're educational or intellectual or physical, will still be there, even as we are applauding these advances. And I don't know that there's one simple solution for that, but it is certainly something that at least I lose sleep at night, being so excited about the advances, but realizing that there are so many patients who will not benefit from them yet. John, you also mentioned, for instance, that even with a curative approach, that there is pre-existing morbidity that will likely still cause some degree of disability, especially as it relates to progressive of organ damage that was already pre-existing in the example that you gave with sickle cell. But I'm wondering, from the Social Security Administration's perspective, when they're thinking about someone who's gone through curative therapy, and an appreciation that that person's needs may not nearly be as simple as one might hope in terms of the actual therapy mitigating risk of disability. Do you want to talk a little bit more about that?
Yeah, sure. So it seems to mostly relate to age and accumulated end organ damage in the case of sickle cell disease, but it's probably true for all other diseases that we try to cure. We're at best left where the patient was when they came to cure. So, for example, we've extended transplants without an upper age limit, without end organ criteria for exclusion. And that has allowed us a better window into what gets better and what doesn't get better. For example, if a patient is in renal failure on dialysis, we don't exclude them. And they don't come off dialysis just because you cured the cause of them going on to dialysis. They continue to go to dialysis on Monday, Wednesday, Friday after that transplant, just like they did before. For example, if they have chronic pain from their bones being riddled with bony infarcts over their life, and they're on chronic pain medications for that, and they're disabled because of that, it doesn't get better with curing their disease. So, you really have to look not just at whether the disease went away, but the state of the patient before they had this intervention. And thankfully, some things do get better. We have patients in heart failure, and that heart failure improves. We've had patients with liver disease, even bridging fibrosis, so the beginning of cirrhosis, and we've had that improve. So the liver seems to be able to recover, the kidneys don't. The heart to a certain extent, the lungs to a certain extent, but that's why I said in my concluding remarks that the younger we start, the better off we'll be, or our patients will be.
And so, say for disease recurrence, David, are there other pre-existing morbidities that some of the patients that you'll be treating have that will continue to cause disability?
I think it's the same issue, that it doesn't cure prior damage. It doesn't cure prior issues. That's so that tells us a couple things. Particularly if you look at some of the alternatives and how we treat patients. Historically, with some of these diseases, they're treated with multiple long-term rounds of very intensive chemotherapy that go on 6 months to 2 years or even longer. And that results in cumulative damage. If you have a treatment, whether it be transplant or CAR T cells or whatever, that has the potential to cure them before you expose them to all this long-term toxicity, should we be thinking about applying these therapies sooner before they accumulate all of this other morbidity? Transplant has been difficult to put into that category because of the very high risk, the very high mortality rate. I caught the end of the last session where someone was saying, do I want to take that chance of dying from the treatment now versus living a little bit longer and having a good quality of life, but knowing that my disease is going to come back. If you had a safe therapy, and certainly a much safer therapy, you could start applying that earlier in the course of the disease. For instance, CAR T cells are now being studied in 3 different randomized controlled trials that have just finished, using them as second-line therapy in lymphoma. So you get your standard first-line therapy, but when a patient relapses, instead of getting more and more chemotherapy and stem cell transplants and more treatment, should you just do CAR T cells before they have all these exposures? And some of the early data via press releases says that indeed CAR T cells may be better than lots and lots more chemotherapy. So you get them earlier.
So Dave, you touched on new studies, and one final question I have for the panel is if you can comment on whether it's a wish list or otherwise, the types of data or additional studies that you believe need to be considered in order for us to assess the long-term outcomes, including disabilities, for these emerging therapies? So either data or new studies?
I can start off by saying I think as transplanters, and I include myself as a member of that community, we need to do a better job of the long-term follow-up studies that look at all of the, the aspects that, the members of the audience are interested in hearing about. I was astonished when on this ASH committee to look at, developing guidelines for transplantation, that the data on long-term effects just don't exist in this disease, and for many transplant applications they don't exist. So for us to do a better job at handling patients afterwards, we need studies that continue to collect all the information that's important to patients and to providers, and those include neurocognitive function, all of these other things that we have so little data on.
I think
I would echo, sorry, David, I was going to echo what John said. I think that we have a unique opportunity to use the registry, the CIBMTR registry, and we are incorporating certainly patient-reported outcomes. But again, I think a greater focus on long-term studies using the registry. So we really collect the real-world data and have real-world evidence from everyone, not just patients participating on clinical trials.
Yeah, I was going to sort of try and engage you, Steve, just in that comment that the CIBMTR collects, thousands and thousands of data points on long-term outcomes. I think as a community, it's dependent on us to provide that data to see these patients long-term. We do need long-term outcome studies. In the field of gene therapy and CAR T cells, this field is in its infancy. For the sake of time, I didn't show one of my slides that show all the different cell therapies that are in development, probably over 1,000 different cell therapies in development by several hundred different companies that are all in various stages of either preclinical or clinical trials. And this field is going to explode. And so now is the time to set up a mechanism to collect this long-term data. But I will throw out one other piece that I think we do know a lot about long-term outcomes and disabilities. I think that some of that information is poorly disseminated. And in addition to doing the research, I think there needs to be a real effort at educating not just the treating community and the transplant community, but also the community physicians who then take care of these patients, because I think that's a huge missing piece, not being aware of what some of these long-term disabilities may be by those people.
Yeah, you raise a great point, David, especially when we think about patients who are long-term survivors, many of whom are no longer treated at their original transplant centers and that are out in the community practices where some of the information that we might be very familiar with is not available to a primary care doctor in a community or a community-based oncologist. And as such, the patient may or may not be getting everything that they need. And so certainly, I think your point is very well taken. John, David, Steve, this has been really a privilege for me to join your panel and to talk about these future therapies. I hope this was useful to the members of the audience from the Social Security Administration. I hope we'll come back and we'll be on the other side with the standard therapy people sometime soon.